Thank you. Well, it's a highlight for me to come and speak to this meeting, and we are going to be talking about the lipid guidelines in downtown Toronto. There's a workshop on Sunday. I'm not actually allowed to divulge what the 2015 guidelines are, but I will talk to you about some of the issues that we are discussing and that you may see. So the guidelines will be presented orally in Toronto this weekend, and then the publication will follow. We are actually seeking some input into the guidelines, and so if any of you are available Sunday morning and you want to come to the workshop, you are welcome to come. Those are my disclosures. So here's just a case presentation. A 60-year-old woman with a history of hypertension, hyperlipidemia, admitted with unstable angina. She had a percutaneous intervention, a stent, and she had a 95% LAD, multiple lesions in the rest of her coronary vasculature. Her father also had heart disease, fatal MI at age 50. She was previously on a statin but stopped because of muscle aches. And these are her on physical exam. She's a little bit obese. She's on antihypertensive combination therapy. So that's zestoretic probably, and then ASA 81 milligrams. So you can see her cholesterol was untreated. So the total cholesterol of 7.1, LDL 4.9. So the one thing I want to say is that for an LDL of around 5, you have to start thinking about genetic causes. So once you're getting above 5, there's no amount of Doritos or McDonald's. I mean, you possibly could if you've got average metabolism and you're just eating 24/7, but once you get up above that range, it's very likely to have a strong genetic component. This woman had a genetic issue. So she was actually then counseled on diet and exercise. She was started on 40 milligrams of atorvastatin, and she's been then increased her walking. She had muscle pain on the statin. She actually gained some weight. You can see her LDL came down to 3. Now the other question now is the Americans have gotten rid of targets, right? You're probably all aware of this. The Americans no longer, as of their 2013 guidelines. And so one of the big, almost dramatic points of the Canadian guidelines, are the new Canadian guidelines going to keep targets, or are they going to follow the Americans and get rid of targets? And so the one thing I can tell you, I'm bound by an embargo, but there are 2 new studies that have come out since the U.S. guidelines that I think reinforce the importance of targets. And so quite possibly you will see that the Canadian guidelines will recommend that we will keep some sort of target for LDL level rather than just fire and forget. So the issues in this patient, is she adequately treated? Is that LDL of 3, is that good enough? And then her myalgias on the statin. And then the other thing was the glycemia. So we see that, you're probably aware of this, that the statins, particularly at the higher doses in people who are a little bit obese, that can hasten the onset of type 2 diabetes. It's quite rare, like patients are now paranoid about it, and you can see it on television and these lawsuits and so on. It's about 1 in 800. It's quite rare, okay? So you can't, it's not like I have started 6,000 patients on statins, so if there really was this epidemic of diabetes with statins, like my clinic would be full of like new onset diabetics, and so I can tell you it's not true. So here's what we're going to talk about today, the little bit on the new guidelines, a little bit on LDL, why I think LDL is important, why we still need LDL targets, a little bit on these new drugs that were just approved about 2 or 3 weeks ago, PCSK9 inhibitors, just so you're aware. So there's a new drug for cholesterol in Canada. These are injectable drugs. They're not statins. People say, oh, injectable statins. No, they're not statins. They are injectable. It's a once or twice a month injection, and the first one was approved, as I said, last month, so I'll talk a little bit about that. And then other non-statins. So we know that, I think up until about 2 or 3 years ago, we used to think that it was statins, and it wasn't even the lipid effect of statins. They're anti-inflammatory, they're magic, anti-inflammatory, anti-thrombotic, anti-growth factor. And so really the lipid is almost an epiphenomenon. But it's not really the main mechanism, or at least that was what people were purporting. It was really the anti-inflammatory effects of statins. But I think we're now back on board that it's really the lipid effects. And so with some of the non-statins that then don't have these other magical effects but do lower lipids, they also have benefits as well. So I'll show you those. So here are the current 2012 lipid guidelines, which are very rapidly going to turn over, like your odometer at like 9999 going to go to the next guidelines in 2015. So our target for high risk was an LDL of 2. And then we had those alternate targets. The one that's really pertinent for Ontario or for, I would say, all of Canada, is the non-HDL. The non-HDL is the total cholesterol minus the HDL, and that's good whether the patient is fasting or not fasting and whether the triglycerides are high. It's a very robust measurement, and there the comparable level is 2.6. And I can tell you for sure that is going to stay in the new guidelines, the non-HDL and in fact non-fasting lipids. So here's what the Americans did. So the Americans took out their targets, they took out their 3 levels of risk, and they say basically, okay, you just say, you look at, you see who was studied in the big studies, and then, okay, my patient, do they fit into one of these 4 categories? So any patient with established vascular disease, any patient with an LDL above 5, any patient with diabetes, so like a type 2 diabetic, basically type 2 diabetic who's had diabetes for 1 day above the age of 40 is, a high-risk patient. Or, type 2 diabetic who's been diabetic for 15 years, or sorry, type 1 that has had diabetes for 15 years and is above the age of 30. So even a type 1 is considered to be at risk, even if they don't have clinical atherosclerotic vascular disease. And then the bottom category, number 4, those are patients that have a lot of risk factors. So those are the multiple risk factor patients. So here we use the Framingham equation because everybody's familiar with it. In the US, they introduced this new equation called the pooled cohort equation that really nobody has heard of, and it only came out in the US guidelines and not really a lot of evidence. That one goes across different ethnic groups. So the Framingham was mainly derived in Europeans. This pooled cohort equation goes into different ethnic backgrounds. So this is more like what the Canadian guidelines are going to look like, is that we're going to say, it's a similar idea. It's like, okay, who is a high-risk patient? And then these were derived from the high-risk patients where the studies were done. So who's a high-risk patient? Well, they're adjusted Framingham score above 20%, so people with a lot of risk factors. Clinical atherosclerosis, so secondary prevention. Most diabetics, I described them to you. High-risk hypertension, that's from the Ascot study. The diabetics are from the CARD study. Abdominal aortic aneurysm, and then chronic renal disease, so that's the SHARP trial. So any of those categories, those are high-risk patients. Then you start with your health modification behavior, diet and lifestyle, and then treat the modifiable risk factors. And then in that little box it says it's clinical judgment. So there's still a place for clinical judgment. So then there is a discussion with the patient. You get the patient to buy in that it's better to be alive than to be dead. And then you talk about statin therapy. So here are the issues in the 2015 guidelines. So were we going to keep LDL targets in some form? Statins are still the foundation of treatment, but there are some cases where you can use a non-statin, and it's quite, it is quite acceptable. We have evidence that it's reducing events. And then finally, should we always be this obsession about fasting lipids, or can we loosen that a little bit? Can we take non-fasting lipids? So the patient comes in at 3:30, you want to find out what their lipids are, you can send them down to the lab. Does it absolutely have to be fasting, or can you, because you know that you're not going to see the patient for another 2 months. So why keep targets? There's all these reasons. By the way, if anybody is super interested, I mean, if your lives have reached the point that that you've got nothing better to do, that you want my slides, you are welcome to have my slides. I will make them available on PDF. You just have to let the conference organizers know, or even just send me an email. My email was at the beginning there. So these are the reasons why we would keep targets. I don't want to go through all the arguments. I just want to show you a few things. So here, statins. It's hard to argue with statins, right? If you enjoy life, if you enjoy the world, you enjoy being around people, then statins, you live longer if you take a statin. So this is the 4S study. the group that was on placebo, their LDL was 4.4. The group that was treated with actually a relatively low dose now of simvastatin, 20 milligrams, their LDL came down to 3.1, and they were still alive. Any point along that line, it's an extra 6 months of life. So it's like an investment. It's like a GIC. You take your statin for 2 years, you live another 6 months. So it's that kind of thing. Now, then there's the side effects, but then you have to balance it out, right? Okay, it's like nothing is free, there's no free lunch, but that's so here. This is now the American. So the Americans will say, here's the survival benefit, say in the TNT study, using 2 different doses of statins. Atorvastatin 10, so you can see now you can't do a placebo study. So that atorvastatin 10 is already pretty good survival versus atorvastatin 80. So the Americans say, okay, well, it's the higher dose that gave the benefit, so you just treat with the higher dose and don't worry about the LDL. But another way of looking at it is that the control group had an LDL of 2.6, which is like our old guideline, and then the more intensely treated group had an LDL of 2.0. So what was it? Was it the 80 of atorvastatin, or was it the fact that they were the LDL of 2.0? Well, the Americans would say, based on this study, oh, well, it was the dose of the drug, so just use the dose that they used in the study and never measure. But it would be like saying at a hypertension conference, just treat with an antihypertensive and then never measure the blood pressure again. And how do you know they're even complying? So, I'm trying to hammer home the point that it's important to consider LDL and to keep treating LDL. Here's another study in acute coronary syndrome. So the control group, now it's unethical to use placebo in high-risk patients. So the control group got 40 of a weaker statin, pravastatin. The more aggressive group got 80 of atorvastatin. So again, if you're just like an absolutely concrete, evidence-based, you'd say, okay, in these patients you only use 80 of atorvastatin. But another way of looking at it is that, okay, the one group had an LDL of 2.6, the other group had an LDL of 1.8. The group that got the LDL of 1.8 did better. Okay, so however, from my point of view, however you get them down to 1.8, if you can do it dietarily, if you can do it with a little bit of a statin plus something else, or if you can do it with an intermediate dose of a statin, some people 80 milligrams is too much. Their LDL comes down to 0.3. Well, then if you're evidence-based, well, don't change the dose. Use the dose they use in the study. Well, so there's got to be some thinking involved. We're thinking people. Now, this was a study that changed things. So this is one reason now why we are keeping LDL in the guidelines, is this Improve It study, which was presented a year ago at the AHA and published in the New England Journal in April. So this was a study in acute coronary syndrome patients conducted over 7 years out of Duke, 25,000 patients. And so the control group was on a statin only, 40 milligrams of simvastatin. Their LDL was already pretty good, 1.8, okay, 1.8. We would say that's a great LDL, you're at your target, good for you. The other group, and then it was divided 50-50, were placebo on top of that, or 10 milligrams of ezetimibe. So ezetimibe has this word on the street that all the pharmacists, it doesn't do anything, it's just a placebo. Well, so here, this is the study that shows that ezetimibe is actually doing something. Okay, ezetimibe, the patients that were on 10 of ezetimibe, their LDL was lowered further down to 1.4. Okay, so that's quite a low level now, right? And then people would say before, well, ezetimibe, because it's not a statin, it doesn't have the magical effects of statin. It's just a stupid drug that works in the intestine and lowers LDL. All it does is lower LDL, so we won't see any benefit. Well, no, you still do benefit. And it's the same paradigm that I'm showing you before, back in the early days, that if you're just using more statin versus less statin, it all tracks with what's happening to the LDL. So you're getting reduction in events here. Now, it's not a blockbuster because it's not a strong LDL lowering drug, but the result is clearly significant in events. So here's a non-statin drug that lowers LDL. I'm going to skip over a lot of this. This study shows that if you do intravascular ultrasound and you have patients on statin drugs, that the lower the LDL on treatment, that line that goes through 0, that means that the plaque inside the coronary arteries is staying stable. It hasn't progressed. Everything above the line means the plaque is progressing. Everything below the line, actually the plaque is regressing. There's a shrinkage of the plaque. This is over a 2-year period. So you can see at around 1.8 it's stable. 1.5 is actually a regression of the plaque. 1.3, the plaque regresses quite a bit. Genetic study, I'm going to skip over this because you're a nice group and it's late in the afternoon. So the point is that that it really is related to the LDL. It's not. I mean, I'm not denying that statins have other effects. That statins do have, if you test them in a test tube, they do have anti-inflammatory effects and they lower C-reactive protein. But I think in 90% of our patients, 90% of the time, that's not what's happening. The pleiotropic effects of statins are not clinically relevant. It's the LDL lowering that's the most important. Now, LDL is just one of many atherogenic lipoproteins. On the left side of the slide, it's also, these are the non-HDL class, so it includes VLDL and remnants and Lp(a). So it's the cholesterol in those that ends up inside the plaque, that forms the plaque. And then on the other side, HDL takes cholesterol out of the plaque. So the second thing I'd like to tell you is this non-HDL. Non-HDL is the total cholesterol, all of the cholesterol, subtract the HDL. So it's everything on the left-hand side. It's all of those atherogenic lipoproteins. And that is good whether the patient is fasting or not fasting, and it predicts events. And in fact, where it has been looked at, and in fact, even LDL is good if the patient is not fasting. So this is one thing that you may see when the new guidelines come out, is that we still prefer fasting lipids, but it's not essential. So that if you are in a, depending on the clinical situation, you certainly can do a non-fasting lipid profile. Okay, now the third part of my talk is these new drugs, these PCSK9 inhibitors. It's a 68-year-old man. So I actually wrote the first prescription. I think they told me it was the first prescription in Canada for these drugs. We just started another patient on it today. So we're starting to use them. They're not for everybody. 68-year-old man, vasculopath, presented with an MI. He wasn't taking a statin because he got a side effect from it. His LDL was 5. What should his treatment be? So here, about a month ago, September the 15th, Repatha. So the drug is called Repatha. It's also known as evolocumab. It's an injectable drug. It looks like an EpiPen. And the patient who gives it like subcutaneously, it's like, or an insulin, like an insulin cartridge. And once a month, or twice a month, the first of the month and the 15th of the month, reduces cholesterol by about 75 or 80%. And it's called PCSK9, proprotein convertase subtilescent kexin 9, PCSK9. Forgive me for the name. I didn't make up the name. It was these guys, Michel Chrétien and Nabil Sayda. So these are Canadian scientists who actually discovered this protein, working in Montreal. And now, 15 years later, we actually have a drug for it. So patients that have a deficiency of this PCSK9 hormone or enzyme, they have low LDL and they have protection against cardiovascular disease. There was this key paper in the New England Journal of Medicine that showed that. Basically, on the bottom left-hand corner in the city of Dallas, there were 85 people that had a deficiency of this enzyme. Their LDL was low. And then there, on the right-hand side, their heart disease rate was almost absent. So they had an LDL of around 2. It was like being born taking a cholesterol-lowering medication, except it was for a genetic reason. They had almost no vascular disease. So pharma then said, we have to try to mimic this effect. And so, again, you're such a nice group. I'm going to show the mechanism here, but it's really not that important. It's a drug that works in the liver. The main thing is that it works in the liver and it helps the liver get rid of cholesterol. Okay? So it's different from a statin. They've tried to give it in pill form. It cannot be given as a pill. It has to be given by injection. So they've tried, believe me. And So it's a monoclonal antibody, so it's like other monoclonal antibodies that are familiar to other fields, rituximab and drugs that are used in Crohn's disease and rheumatoid arthritis. They're very potent LDL reduction, 65 or more, non-statin mechanism, monoclonal antibodies, very competitive environment, so there's at least 2 more of these drugs that will be approved, and we have a very early signal that they cut heart attacks as well. So this is how the monoclonal antibodies look. This is how the cartridge looks up in the right-hand corner. So the first one that is on the market is evolocumab, that's from Amgen. Then Sanofi has one as well, alirocumab. Very, very similar. They work the same way. The only one that's so far approved in Canada is evolocumab. So this is what happens to the lipid profile. I'll just show you here. This was the effect on patients with genetically high. So these are patients that are on the statin. And on the statin, their LDL is 3.6. So in this little study, half of them got placebo, half of them got the injection, either 75 or 150 milligrams every 2 weeks. And you can see the LDL came down to below 2. This is the lowest LDL that these patients have ever had. These are these familial hypercholesterolemia patients. There's 3 of them. There's actually Pfizer has one, the one in the middle, bococizumab. So they all have very similar effects. It depends on finding the right dose and finding the right interval, but generally it's the 150 milligram dose every 2 weeks that seems to be the most effective. Lowers Lp(a), that's really interesting for a lipid geek like myself. So there was a study called the Osler study, named after a famous Canadian, William Osler, the doctor who started the field of internal medicine. These are all of the outcome studies that have been done with these drugs. So there have been more than 10,000 patients now in the world that have used these drugs. So Canada has been a big contributor to these studies. So this was the one that resulted in the drug being approved in the United States and in Canada. So these were patients who on standard therapy, their LDL, so this is including statins, so they were all taking a statin, their LDL was 3.1. With the drug, their LDL came down to 1.2, and it was sustained over a 1-year period. And then this is what happened to the survival curves. So starting even at 60 days, with the LDL down now 1.2, okay? This is not a statin, okay? This is just an LDL lowering drug. Huge survival benefit. Few side effects. The one side effect I want to show you about halfway down, neurocognitive. So people find that their memory is a little cloudy. They're not as good with names. That's my baseline state anyway. I don't take a statin, fortunately, or I don't have to take one. But they're monitoring that now. So that's the one signal that's come out of these studies, is that there is a change in cognition, but it's still quite rare. And now they're watching it. They're doing studies of like 20,000, 30,000 people. This is the other drug, alirocumab, published back-to-back in the New England Journal of Medicine, but it did the same thing. The LDL was around 3.1 on the placebo, about 1.2, and then drifted up to 1.5 on the active treatment, and then identical result, a reduction by 50% of cardiovascular events within a year. The curve started to separate within about a month. And same sorts of side effects here. There's slightly more muscle aches, but nothing like what we see with the statin. It's and no difference here in neurological events or neurocognitive disorders. So these drugs now, when we rank them, they reduce LDL by quite a lot, and they reduce events by quite a lot. So they're sort of even more potent than statins. They're on the right-hand side of the efficacy curve. My last part of my talk, I have about 2 or 3 minutes. So this is now non-statins. So non-statins, so the PCSK9 inhibitors are a non-statin. Remember, the statins are still our favorite. You still go with the statin when you can. They're generic, they're safe, they have a 30-year track record. We know what we're dealing with. But there are these non-statins. So this was a review that I was asked to write for the American Heart Association. So we know, for example, the bile acid sequestrants, cholestyramine versus placebo. These are studies going back to the 1980s. When you compare, say, cholestyramine or colesevelam against placebo, it reduces events. When you compare it against background statin use, that benefit disappears. But if you are comparing it strictly against placebo, and the same with the fibrate on the right-hand side, there is a reduction in events. Here's another fibrate study. So the fibrates compared to placebo, they are reducing events in properly selected patients. The problem is that now nobody at risk is only on placebo. Everybody starts out on a statin, and then you put a fibrate on top of it. So this is the Accord study. And then it says, oh, the fibrate's not doing anything. Well, everybody's already well treated on a statin in this group. So here, incrementally adding a fibrate on top is probably not doing anything except in the patients with high triglycerides. Same thing with niacin. Niacin on its own against placebo reduces events. Niacin on background statin therapy doesn't do anything. So there's this sort of table here. Depends, so are these other drugs that we use for lipids, are they any good or are they just garbage? It depends. It depends on the background. So if there's no background statin, then they actually do something. Bile acid sequestrants, fibrates, and niacin. With background statins, the ezetimibe study, I showed you the IMPROVE-IT study, but then fibrates and niacin don't appear to have an effect if there's background statins. The statin already takes your patient a long way, and it's hard for these older drugs to show a benefit on top. So here are my take-home points. So the guidelines, so I can tell you now, if you just promise not to tell anybody, to keep the secret, the Canadian guidelines will be keeping targets, mainly because we think for many reasons it's important to follow LDL. We need to have something to treat towards, both for physicians and for patients. And also we have drugs other than statins that lower LDL. If the benefit was only isolated to statins, then we would just say, like the Americans, put your patient on a statin and then don't worry about it. But here, there are two recent studies, the ezetimibe study and the PCSK9 inhibitor studies that show that you can use something other than a statin to lower LDL, and it improves events as well. And so now we're back to keeping an eye on the LDL, trying to get it low. Statins, use them first. Emerging therapies, PCSK9 inhibitors. The older drugs, we don't throw them away either. They have their place. They're effective versus placebo. Certain subgroups may benefit. Combination with statins is safe, but the statins are already doing a big job on their own, so you wonder what's the incremental benefit. Ezetimibe added on top does have an incremental benefit. So that's the end of my presentation. Thank you very much. Right, it's a great question. So the question was, for non-fasting, what happens to LDL? And so it's only a problem if the triglycerides are very high. So what the revised guidelines